Imagine a condition that makes your skin as thin and fragile as wet tissue paper. But then your body's desperate attempt to heal it ends up wrapping your anatomy in this rigid, suffocating concrete.
It's quite the visual.
Right. Today, we are looking at a total medical paradox. We're unpacking a condition that affects a surprisingly large number of people, yet almost nobody talks about it openly, mostly due to the intense stigma surrounding it. The topic is male penile lichen sclerosus.
Yeah, and it really is an incredibly misunderstood condition, often just hiding in plain sight. For this deep dive, we are synthesizing some heavy materials. We've got the latest national dermatology guidelines, urological data, and, surgical insights to really cut through that silence.
Which is so needed.
Exactly. We want to demystify exactly what this disease is, the underlying biology of, why it happens, and how modern medicine is actually managing it.
And whether you are a medical professional or maybe someone navigating these symptoms yourself, or honestly just an insanely curious learner who wants to understand the blind spots in human health, we are going to equip you with a really comprehensive understanding of this highly underdiagnosed issue.
Right, and to even understand the scope of the problem, we have to look at the terminology first because it can be a little confusing. Historically in men, this condition was called balanitis xerotica obliterans, or BXO.
I think you might still see that on older medical charts.
You definitely do, but the broader medical community now considers BXO an outdated, purely descriptive term. The actual accurate pathological diagnosis is lichen sclerosus. Fundamentally, it is a chronic, scarring, inflammatory skin disease.
And looking at the demographics, the prevalence is striking. The data estimates it affects somewhere between 1 in 300 to 1 in 800 individuals.
Which is not rare at all.
No, not at all. And for men, it primarily targets the glands, which is the head of the penis, and the prepuce, the foreskin. Also, the onset usually peaks at 2 distinct times, right? During childhood, and then again much later in life, typically for men in their 50s and 60s.
Right, and there is also this very specific anatomical requirement for this condition to take hold in men. Crucially, it almost never occurs in men who were circumcised early in life.
Okay, really?
Yeah, the presence of that specific prepuce tissue is central to how the disease actually develops.
Oh. Okay, so the visual symptoms are where that tissue paper comparison comes in. The guidelines describe the hallmark sign as the skin losing its natural pigment, just turning pale or stark white.
Exactly.
It loses its elasticity and becomes incredibly thin and fragile. Patients experience small cracks, bleeding points, and blood blisters just from minor friction.
But that fragile surface is hiding a much more destructive process underneath. The clinical sources describe severe structural changes over time. Patients develop what's known as phimosis, where the foreskin tightens to the point that it becomes completely impossible to retract.
Which obviously leads to excruciatingly painful erections and tearing during sex.
Yeah, it's awful. And there is also a symptom called wasting, where the retracted foreskin draws in around the shaft of the penis, acting like a tight, restrictive rubber band.
Okay, let's unpack this because that brings us back to the paradox. I am struggling to reconcile how skin can become as fragile and thin as tissue paper on the surface, but at the same time cause such rigid, constricting scarring and tightening.
Well, it comes down to a localized battleground involving the immune system. In lichen sclerosus, the immune system mistakenly identifies the healthy basement membrane of the skin as a threat.
So it's literally attacking itself.
Yes. It sends in inflammatory cells that literally chew up the normal elastin and healthy collagen. That destruction is what causes the surface to thin out, lose its blood supply, turn white, and tear easily.
So the surface architecture is just being actively demolished.
Yeah, but your body doesn't just leave a wound open, right? It tries to repair the constant microscopic damage. The localized cells, which are called fibroblasts, go into a total panic state.
Oh, I see.
They start laying down massive amounts of scar tissue to bridge the gaps. And this fibrotic scar tissue is mostly dense, inflexible collagen. As it builds up layer by layer beneath that fragile surface, it shrinks and constricts.
Wow, okay, so that localized structural collapse is what creates the tight bands, the wasting, and the phimosis.
You got it.
But if the immune system is launching this unprovoked attack on the local tissue, what triggers the alarm bells in the first place? There must be a reason the body suddenly treats its own skin as a hostile invader.
The prevailing medical consensus points to an autoimmune origin. The patient's wider health profile often reflects this systemic confusion. Lichen sclerosus is frequently linked to other autoimmune and atopic conditions.
And atopic just means, like, a genetic tendency to develop allergic diseases, right?
Exactly. So we often see this condition overlapping with things like thyroid disease, type 1 diabetes, asthma, and severe eczema.
There is also a genetic component mentioned in the clinical data, noting that about 10% of patients have a direct family history of the condition. But having the genetic blueprint for an autoimmune disease doesn't mean you will automatically develop it. You generally need an environmental trigger to activate it.
Which brings us to a major insight from the Primary Care Dermatology Society, the urine occlusion theory.
Urine occlusion theory.
Yeah, this explains why the anatomy is so critical and why this is almost exclusively seen in uncircumcised men. After passing water, a microscopic drop of urine can easily get trapped or occluded between the tightly opposed mucosal surfaces of the inner foreskin and the glands.
Right, and because it's a closed, moist environment, that drop doesn't just evaporate, it sits there, maintaining constant contact with the skin.
And urine is biologically active. It contains waste products, specifically urea. When urea breaks down, it forms ammonia, which raises the local pH and creates a highly alkaline environment.
Oh, wow.
Yeah, so if a patient has that underlying genetic susceptibility, that trapped microscopic pool of alkaline waste acts as a chronic low-grade chemical irritant. Over time, that constant irritation provokes the local immune system, initiating that devastating cycle of tissue destruction and dense scarring we just detailed.
The situation is then compounded by a biological reaction called the Koebner response.
Right.
This is a well-documented dermatological phenomenon where physical friction or trauma to the skin actually triggers or exacerbates an underlying condition.
Exactly.
So the chemical irritation from the urine causes itching. The patient naturally rubs or scratches the area or maybe experiences friction during sexual activity. That physical trauma acts like a flare gun for the confused immune system, drawing even more inflammatory cells to attack the area.
It creates a vicious, self-sustaining loop of damage. The irritation leads to friction. The friction leads to inflammation. The inflammation leads to scarring, which then traps more urine, leading to more irritation.
Here's where it gets really interesting, though. Looking at that loop, the most obvious solution seems incredibly simple. I mean, if trapping a microscopic drop of urine is the primary environmental trigger, wouldn't simply scrubbing the area with soap fix it? Just wash the chemical irritant away.
It seems so logical, but dermatologists actually consider aggressive washing to be one of the most harmful things a patient can do.
They really?
Yeah, we have to look at the skin's barrier function. Healthy skin relies on an acid mantle, a thin layer of natural oils and slightly acidic secretions that protect against bacteria and environmental damage. Harsh soaps completely strip away those protective lipids.
Oh, I get it. And if you are aggressively scrubbing skin that is already inflamed, thinned out by an autoimmune attack, and stripped of its natural oils, you are causing microscopic abrasions. You are artificially inducing the Koebner response.
Exactly. Plus, the chemical surfactants and artificial fragrances in standard soaps often trigger irritant or allergic contact dermatitis. You are essentially pouring a chemical accelerant onto an existing autoimmune fire.
Wow.
The national guidelines are emphatic about this point. Regular soap and overwashing must be avoided. Gentle, non-irritating care is mandatory to avoid worsening the flare-up.
This highlights the need to bust some pervasive myths, too. When people hear about a genital skin condition that involves inflammation and tearing, the assumptions tend to be incredibly judgmental.
Oh, definitely. But the clinical data is unequivocal here. Lichen sclerosus is not contagious. It is not a sexually transmitted infection. And despite the fact that trapped urine acts as a trigger, it is fundamentally not caused by poor personal hygiene.
It is an autoimmune response.
Right. You cannot catch it from an intimate partner, and you cannot transmit it to a partner.
But the fact that it is not contagious doesn't minimize the danger to the patient. If a patient assumes it's just a hygiene issue or feels too embarrassed to seek help, the inflammation goes unchecked for years. The chronic scarring doesn't just stay on the surface, it starts compromising the underlying anatomy.
Yeah, the urological implications are severe. The opening of the penis, where urine exits the body, is called the urethral meatus. The aggressive, concrete-like scarring from lichen sclerosus can creep into that opening and physically choke it, narrowing the tube. This stricture is called meatal stenosis.
And the symptoms outlined in the urological data sound incredibly disruptive. Patients experience urine spraying, constant dribbling after urination, a noticeably weak stream, and the need to urinate frequently, including waking up multiple times throughout the night.
Because the exit pipe is narrowed and rigid, the bladder has to generate significantly more pressure to force the urine out. This back pressure causes the bladder muscle to thicken and become overactive, which drives that constant urgency.
That sounds miserable.
It is. And once the scarring causes a physical stricture like meatal stenosis, topical treatments are no longer sufficient. Patients require surgical intervention. Urologists may perform a urethral dilation to forcefully stretch the opening, or a medoplasty, which is a surgical reconstruction of the urethral opening to restore normal flow.
Beyond the plumbing issues, there is a much darker, long-term implication that requires attention: the cancer connection.
This is perhaps the most critical piece of information a physician must convey. The overall lifetime risk of a man with lichen sclerosus developing penile cancer is relatively low, with literature estimating it between 2% and 12.5%.
Yeah.
However, if you look at the statistics from the other direction, up to 50% of all diagnosed penile cancers are associated with a background of lichen sclerosus.
Wait, half of all penile cancers originate in tissue affected by this condition.
Yes. The chronic, unrelenting inflammation forces the local cells to constantly regenerate to repair the damage. That rapid, sustained cellular turnover over a period of years creates a really volatile biological environment. Every time a cell divides, there is a risk of a copying error.
And eventually, those mutations can accumulate, leading to malignant changes, specifically squamous cell carcinoma. The data also notes a slightly increased risk of penile melanoma.
Because of that specific pathway to malignancy, the dermatology guidelines stress the absolute necessity of lifelong self-examination. Patients are instructed to continuously check for hard lumps, sudden persistent thickening of the skin, or ulcers and sores that refuse to heal.
Any of those changes require an immediate skin biopsy to rule out penile intraepithelial neoplasia, or PIN, which is a premalignant disease state. Dealing with all of this, painful sex, urinary dysfunction, and the looming fear of cancer, the psychological toll this must take on a patient requires immense mental resilience. How crucial is early diagnosis to preventing these severe complications?
It's vital. Once a patient overcomes that stigma and receives an accurate diagnosis, the goal is to halt the inflammatory progression before the anatomy is irreversibly altered. The gold standard, first-line medical defense, is a 3-month intensive course of ultra-potent topical corticosteroids. The most common is an ointment called clobetasol propionate.
This introduces a fascinating contradiction that causes massive anxiety for patients. The patient leaflets specifically warn about the pharmacist's insert inside the medication box. The label will explicitly state, "Do not use on genitals, steroids, thin the skin."
It creates a massive barrier to compliance. A patient reads that, looks at their skin, which is already tearing like tissue paper, and assumes the doctor has made a dangerous mistake.
Right. So how does applying a skin-thinning cream to tissue paper skin actually heal it?
It requires understanding the specific mechanism of the steroid. For a person with healthy, normal skin, chronic use of an ultrapotent steroid will indeed suppress normal collagen production and cause the skin to thin.
Okay, that makes sense.
But in a patient with lichen sclerosus, the biological playing field is entirely different. The autoimmune disease, the rogue lymphocytes attacking the elastin, is what is actively destroying the tissue. The steroid acts as an immunosuppressant.
Ah, so it acts like a targeted chemical fire blanket.
Exactly. It penetrates the tissue and shuts down the aggressive immune cells causing the destruction. Once that inflammatory attack is suppressed, the body's natural regenerative processes can take over without interference. The skin is finally allowed to heal, and it actually thickens back to a normal, healthy state.
That's incredible. The steroid effectively reverses the thinning because it removes the disease that was causing it.
Yes. Patients just have to strictly follow the tapering schedule set by their dermatologist, usually starting with daily application to quench the active flare-up, then slowly reducing to a maintenance dose, perhaps once or twice a week, to keep the immune system permanently subdued.
But the surgical guidelines note that for about a third of men, the foreskin becomes too heavily scarred and fibrotic. It simply doesn't respond to the topical steroids.
When the fibrosis is that severe, urologists recommend a radical circumcision. This is entirely different from a cosmetic procedure. It is a day-case surgery, usually under general or local anesthetic, where the surgeon removes the entirety of the inner and outer foreskin, leaving the glands completely exposed.
And by removing that specific prepuce tissue, you are removing the localized mucosal environment that traps the alkaline urine. You eliminate the trigger, and you remove the primary tissue that the immune system is targeting.
For the vast majority of patients who undergo it, the procedure is curative. It permanently halts the progression of the disease and drastically lowers the associated cancer risk because the volatile environment has been physically excised.
The sources also mention emerging regenerative therapies. Clinics are utilizing platelet-rich plasma, or PRP, which is sometimes marketed to men as the P-shot.
PRP is a fascinating biological tool. A clinician draws a small amount of the patient's own blood and places it in a centrifuge. The high-speed spinning separates the red blood cells from the plasma, isolating a concentrated serum of platelets. These platelets are packed with growth factors and cytokines. When injected directly into the scarred penile tissue, those growth factors stimulate angiogenesis, the creation of new blood vessels, and promote tissue regeneration and elasticity.
It sounds like a powerful way to repair the architectural damage. However, the medical consensus is clear that while PRP can significantly aid in symptom relief and tissue recovery, it is not a definitive cure for the underlying autoimmune disease, right?
Exactly. The immune system is still primed to attack, so maintenance therapy and regular dermatological follow-ups remain essential. Alongside medical interventions, patients have to implement rigorous daily self-care routines to manage the physical triggers.
Minimizing friction and chemical irritation at all costs.
Right. This means washing exclusively with emollient soap substitutes rather than foaming shower gels, which we know strip the lipid barrier. It involves gently dabbing the area dry after urination to prevent the Koebner response and keeping pubic hair trimmed to avoid mechanical friction against the fragile skin.
The guidelines also heavily emphasize the use of barrier creams. Applying a layer of Vaseline or yellow soft paraffin creates a physical waterproof shield that prevents that microscopic drop of urine from ever touching the skin. But this introduces a highly surprising and specific warning from the NHS guidelines.
Yeah, it sounds alarmist, but it is a critical safety warning regarding the chronic use of oil-based emollients.
So what does this all mean for daily life? You're using these oil-based barrier creams to protect your skin. But if they soak into your cotton underwear or bed sheets, they become highly flammable.
It's true. Over time, as those oils accumulate and dry within the fabric fibers, they undergo a chemical oxidation process. This drastically lowers the ignition point of the fabric, making the clothing highly flammable.
That's terrifying.
If a patient wearing clothes saturated in dried emollients is near an open flame, a space heater, or a lit cigarette, the fabric can catch fire with terrifying speed. Patients are instructed to wash their clothing and bedding at very high temperatures to break down the oils and to strictly avoid smoking or naked flames while undergoing these daily treatments.
It really grounds the discussion in the reality of chronic disease management. Even the most seemingly benign, over-the-counter moisturizers have physical properties that demand respect when integrated into a lifelong medical routine.
Taking a step back, penile lichen sclerosus reviews itself as a deeply complex condition. It is an autoimmune misfire that simultaneously destroys the skin's surface while suffocating the anatomy in dense restrictive collagen.
Yeah.
It carries a heavy physical burden of urological and sexual dysfunction, a profound psychological weight, and a legitimate risk of cellular mutation leading to cancer.
Yet the most crucial takeaway from all these clinical sources is that it is highly treatable. Whether a patient uses ultra-potent steroids to paradoxically thicken the skin by suppressing the immune attack, utilizes regenerative PRP, or undergoes a curative radical circumcision, modern medicine has clear, proven pathways to manage and arrest this disease.
Absolutely.
The biggest barrier to healing is silence and delayed diagnosis. If you or someone you know are experiencing these symptoms, there is no need to suffer in silence. Medical science has clear, effective pathways to manage this.
And as we look toward the frontier of managing this condition, we know that the Koebner response and the alkaline chemical structure of trapped urine are the physical triggers that provoke the immune system.
Right.
It raises a really compelling concept for future research. Could the future of preventing lichen sclerosus flare-ups lie not in treating the skin itself, but in altering the chemical composition of a patient's urine, neutralizing the urea and ammonia to make it completely non-irritating to the mucosa? It's a fascinating biological question to consider.
That is definitely something for you to mull over long after this deep dive ends. Thanks for joining us.